Okay, so I'm going to go ahead and get started. So for this webinar, we're going to be talking about sentinel lymph nodes in endometrial cancer. Joseph Dottino, one of the GYN oncologists here at Beth Israel Deaconess Medical Center. And thank you for joining or joining in the future as this is being recorded. Just to give some, or my only disclosure is that I have no related disclosures related to the topic of this talk. And tonight I'm going to be talking about sentinel lymph nodes and endometrial cancer. I'm going to give an overview of background related to endometrial cancer and why we do sentinel lymph nodes, the technique itself, and then just a little bit of data on why we know this works. And I'm going to limit this talk to around endometrial cancer. We do use sentinel lymph nodes in other disease sites and other not gynecologic disease sites, but I'm going to limit this to endometrial cancer. This is geared towards a general audience, so I'm going to be a little superficial in what I'm talking about, but if there's questions for anybody who's here, I'm happy to go into more detail or communication after this webinar. And then if there is any additional questions just generally about this, I think we're going to be able to have some way of communicating through the chat and or verbally. Okay, so just some general background about endometrial cancer. From 2023, so from last year, there was approximately 66,000 new cases in the United States. The majority of cases of endometrial cancer are going to be early stage. The majority of those cases are also going to be low or intermediate risk. Generally speaking, the standard of care approach involves surgery, so surgical resection of the cancer with a total hysterectomy, removal of the tubes in the ovaries, and assessment for metastatic disease, usually with some evaluation of the lymph nodes. The lymphatic system is part of our immune system. It consists of a network of lymphatic vessels, depicted there on the left with the yellow channels, and hundreds of lymph nodes throughout our body. And those lymph nodes that are represented there by those what look like yellow cotton balls following our vessels. And these lymphatic vessels and nodes traffic lymphatic fluid and immune cells throughout the body. But cancers also can be trafficked through the lymphatic system as well. And included in those cancers are endometrial cancers that do have a risk of spreading to the lymphatics, with some exception. So the regional nodes, lymph nodes will drain specific organs in a hierarchical fashion, meaning that for the uterus, or where endometrial cancers are, will drain in a predictable fashion in lymph nodes following those great vessels draining the pelvis. And historically, staging of an endometrial cancer, in addition to doing a hysterectomy and removing the tubes and ovaries, would involve a complete lymphadenectomy of these regional lymph nodes, so the pelvic lymph nodes and periaortic lymph nodes, as part of the assessment for metastatic disease. So meaning that, traditionally speaking, when we talk about assessment of lymph nodes, that really meant removing all those lymph nodes along in the pelvis, along the great vessels, going up along the aorta. And that information really contributes to our modern staging. So, whereas the earliest staging for endometrial cancers was primarily clinical and dichotomous, so uterine confined or metastatic disease, in the late 1980s. There was a shift from clinical staging to surgical staging, meaning after some imaging to assess for distant metastatic disease, surgery is performed to identify microscopic spread of endometrial cancer. There on the right of the slide is the 2009 FIGO staging. And you can see that in the early stage disease, where again, most endometrial cancers are going to be identified, this is defined by the depth of invasion or local regional spread. Nodal involvement or lymph node metastasis upstages these cancers to stage 3. But also within the staging system does describe not just which lymph nodes are involved, but also the size of the metastasis, which has some implication for prognosis. I would be remiss if I didn't point out that there are now more recent staging guidelines from FIGO that have been released that have not universally been adopted yet, but this new staging system does not only include staging, meaning where the cancer is as part of the stage, but also begins to incorporate some more histopathologic features of endometrial cancer into describing stage, because as well as molecular features. We've increasingly identified there's a body of literature supporting that some of the molecular features of endometrial cancer really do inform prognosis to a great degree. So when we talk about the histopathology, we are talking about the cell types. So whether it's the most common type, endometrioid, or higher risk cell types like serous or clear cell. The grade, meaning the complexity, which confers some information about aggressiveness of tumor, or lymphovascular space invasion, subtle involvement of other areas of the uterus. But also these molecular characteristics may include things like mismatch repair deficiency, which tell us about vulnerability of these cancers to immunotherapy. Staging, or where the cancer is, really informs not only the prognosis of this cancer type, but also risk of recurrence, and helps us to tailor treatment strategies. So after surgical resection, if we identify patients who have a higher stage disease, rather than using surgery alone or adjuvant local radiation, this may mean the addition of chemotherapy, chemoradiation, or systemic therapy with a combination of chemotherapy and immunotherapy if nodal disease or higher stage disease is identified through our surgical staging. So why do we perform a surgical staging for lymph nodes? Why do we remove the lymph nodes to identify metastatic disease? Or a more relevant question, I guess, would be: why don't we just use ultrasound or a CT scan to identify that metastatic disease? Well, this classic GOG study from Dr. Kriesman back in 1987. Looked at patients, tried to characterize the risk of lymph node metastasis based on patients who otherwise had clinical stage 1 disease. And they identified that there was about an 11% chance of having a positive lymph node when it was otherwise seen that the disease was confined to the uterus. And fewer than 10% of those patients who were identified as having positive lymph nodes after having a lymphadenectomy, surgically removing those lymph nodes, had disease that had lymph nodes that were grossly enlarged, meaning that we were identifying lymph node metastasis through surgery that may otherwise be missed simply by imaging criteria. This study also identified the phenomenon that the risk of lymph node metastasis was directly related to the characteristics of the cancer itself, meaning that for patients who had deeper invasion of that cancer into the wall of the uterus, or a higher grade, a more aggressive histology, all would be related to the risk of lymph node metastasis. When we think about surgical removal of the lymph nodes or lymphadenectomy to identify metastatic disease in endometrial cancer, it's important to point out that really the value seems to be as a prognostic indicator for disease recurrence, or a way to guide our treatment to add adjuvant therapy for treatment of advanced stage disease. Meaning that studies have demonstrated that with removal of all lymph nodes, the act of removal of the lymph nodes themselves that are otherwise apparently normal looking does not seem to improve survival in endometrial cancer. And again, that is not to diminish the prognostic value of identifying microscopically metastatic disease, but just the act of removing all of the lymph nodes along in the pelvis and along the aorta does not seem to improve survival. One thing that a complete lymphadenectomy does, however, is increase our risk of morbidity related to that surgery. So the risk of lymphedema or swelling, especially of the lower extremities with this procedure. And also, obviously, longer operating room times to perform a complete lymphadenectomy. There's other randomized data in addition to the study that's highlighted here that support this lack of survival benefit in a systematic complete lymphadenectomy. Well, if we know that there is a lack of therapeutic benefit in removing all of the lymph nodes, and that there is an increased risk of lymph nodes for those patients with higher risk disease in the uterus, a natural question may be, can we omit a complete lymphadenectomy in otherwise low-risk patients? In this observational study from the Mayo Clinic, tried to answer that question, where they identified uterine-confined endometrial cancer and looked at lymph nodes to identify, are there patients who have lower risk disease such that we can perhaps not perform a lymphadenectomy because that risk is so low. They identified that patients with a tumor diameter less than 2 centimeters, endometrioid histology, and low grades, so grade 1 or 2, and less than 50% invasive, meaning that the tumor involved less than half of the muscle of the uterus, and in a very low, less than 1% risk of lymph node metastasis. And this was compared to an approximately 50% risk in this series for those patients who did not meet this otherwise low-risk criteria. This criteria, which is sometimes called the Mayo criteria, has been subsequently validated in prospective and retrospective studies. Now, one limitation of this approach is that determination of a low-risk patient in this series is based on pathologic evaluation of the hysterectomy specimen. And so therefore, categorizing patients into this criteria would involve performing a hysterectomy. In order to make this decision intraoperatively to decide whether or not a lymphadenectomy should be performed, this would involve intraoperative pathology or frozen pathology. And we do know that this may be variable based on the clinical setting, meaning that depending on the resources available to the surgeon or to the hospital where this is performed, an intraoperative pathology may not identify those low-risk patients accurately, and therefore it may mean deferral to final pathology and return to the OR for a second surgery for lymph node evaluation in that case. Given that there's no survival benefit for a complete lymphadenectomy, but a significant value in identifying those patients who have a nodal metastasis, we want to be able to triage patients accurately to treatment after surgery. We still want to be able to gain the information that would be obtained from a complete lymphadenectomy while minimizing some of the morbidity that is related to a complete lymphadenectomy, such as the higher rates of lymphedema and longer operating times. This is especially true given that most patients will be low risk for nodal metastasis, and thus would have a disproportionate risk associated with a full lymphadenectomy. Therefore, the use of sentinel lymph node mapping and biopsies offers a targeted alternative to a complete lymphadenectomy. This technique involves the injection of dye at the site of the tumor or the organ to identify those primary draining lymph nodes, allowing for a selective removal of nodes, which would be at the highest risk for nodal metastasis. And so we would be able to obtain all the information about lymph node status while minimizing the morbidity that would have been otherwise related to resection of all the nodes. And instead, we could only remove a few. This technique of sentinel lymph node mapping and biopsies was originally described in penile cancers. This technique has been utilized in other gynecologic and non-gynecologic cancers. So breast cancer, vulva, cervix cancers. This can be performed with blue dye, isosulfan blue, a radiocolloid tracer, which is technetium-99, or perhaps most commonly today, indocyanine green or ICG dye. In the case of blue dye, this is visible to the naked eye, whereas a radiocolloid tracer would require a specialized probe to identify that dye in nodes. Indocyanine green is identified using a near-infrared fluorescent imaging or a specialized camera. Sentinel lymph node assessment is feasible both with laparotomy, so through a traditional open incision, as well as minimally invasive surgery. In endometrial cancer, standard of care is to perform a minimally invasive surgery. And this technique using sentinel lymph node assessment is well suited to minimally invasive surgery and may be used with either traditional laparoscopy or with robotic-assisted laparoscopy. This slide is from the NCCN, or the National Comprehensive Cancer Network Guidelines, an excellent resource for both providers and for patients. This describes the injection of the sentinel lymph node dye. At the top of the screen, those three circles are cartoons that represent the cervix, and those points are sites of potential injection of the sentinel lymph node dye. You can see illustrations of the use of blue dye or green dye below, where that dye is injected into the cervix and then that dye travels to the regional lymph nodes along the vessels. This injection is performed in the operating room after anesthesia is administered at the very start of the surgical procedure, thus allowing for the sentinel lymph nodes to be mapped and removed prior to hysterectomy. This is the same illustration that I used earlier in the presentation to describe the sites of regional lymph nodes related to the uterus. After the dye is injected, one or two lymph nodes on either side would be identified as lighting up as those primary draining lymph nodes to be removed. Intraoperatively, this is now through a minimally invasive approach. On the left, you can see what the pelvis, just looking through a white light camera. And then on the right, through near-infrared fluorescent imaging, the dye, the green, in this case, indocyanine green dye that's injected, fluoresces and lights up and identifies at the top, you see the sites of injection, and then below, the lymph node channel, that green line, leading to then at the corner of that screen in the bottom panel D, that primary draining sentinel lymph node. And so it identifies that singular or one or two lymph nodes on that side to be removed preferentially. One additional principle is that in the case of sentinel lymph nodes, we may be able to identify not only the first draining lymph nodes, but often the dye may travel to more than one node. This doesn't mean that all nodes would need to be removed, but rather the sentinel lymph node principle should identify those primary draining nodes and not what we would refer to as second echelon nodes, or those nodes where the dye travels to after draining to the first sentinel node. And so in this case, we really want to prioritize removing those highest risk or first one or two nodes. The accepted algorithm for approach to sentinel lymph node mapping and resection does include an initial assessment of the peritoneal cavity, the surface of the uterus, to evaluate for metastatic disease. In addition to removal of all nodes that are identified as sentinel lymph nodes, any suspicious nodes, either identified through preoperative imaging or at the time of surgical evaluation, should be removed regardless of mapping, regardless of whether or not the dye identifies those nodes as sentinel lymph nodes. So, to put this another way, if the sentinel lymph node dye maps to a node, but nearby that node there is a concerning, pathologically enlarged, worrisome appearing lymph node, that node should also be removed at the time of surgery. In the case where there is no mapping of the sentinel lymph nodes on a hemipelvis or a singular side, because this is a technique that should identify bilateral lymph nodes on either side of the uterus, either side of the pelvis. If there is no mapping, then a side-specific lymphadenectomy should be performed, meaning that if the dye fails to identify lymph nodes on one side, then all of the pelvic lymph nodes on that side should be removed. This is because that this may be a failure of technique, or it may confer a risk of tumor obscuring the lymphatic channels and thus not allowing the dye to travel to nodes to identify a sentinel lymph node. And so when patients undergo this procedure of a sentinel lymph node mapping and removal, we should also discuss with them the possibility of needing to remove more lymph nodes than simply the sentinel lymph node, or more lymph nodes if the sentinel lymph node does not map. Another significant component of sentinel lymph node mapping and removal is ultrastaging. And this describes the pathologic assessment of those lymph nodes that are removed by sentinel lymph node mapping and then resection, that goes above and beyond the assessment performed for nodes that are non-sentinel. Because only one or two lymph nodes are removed, the processing is more intensive, meaning that whereas non-sentinel nodes may be only halved and then using only H&E staining to identify for nodal metastasis, in ultrastaging, the lymph nodes are serially sectioned at smaller intervals, and deeper levels of immunohistochemical assessment are performed to identify low volume metastasis, such as micrometastasis or isolated tumor cells, subtle findings of spread of disease that may otherwise not be able to be performed when many lymph nodes are removed as part of a standard complete lymphadenectomy. It's important to note that no prospective randomized studies have evaluated survival using the sentinel lymph node technique as an alternative to complete lymphadenectomy. Again, we have noted data identifying an absence of therapeutic benefit for a complete lymphadenectomy. There is a rich body of literature that has evaluated this accuracy of sentinel lymph node mapping and biopsies in endometrial cancer, as well as a rich body of literature identifying similar rates of identifying metastatic disease and retrospective studies that have identified a comparable survival benefit in this population. I'd like to highlight here one such prospective study that is really foundational into our understanding of the accuracy of sentinel lymph nodes. This trial, the FIRES trial, the first author being Dr. Emma Rossi, it was published in 2017 in The Lancet. It was a prospective multi-center cohort study that evaluated sentinel lymph node mapping in endometrial cancer. And this was a true validation study, meaning that the aim of the study, the primary aim of the study, was to measure the sensitivity and the negative predictive value of sentinel lymph node mapping compared to our gold standard of a complete lymphadenectomy. And the way that this was able to be done and how validation studies in sentinel lymph nodes are performed are that patients underwent the sentinel lymph node mapping procedure and removal of sentinel lymph nodes, followed by, in that same surgery, a complete lymphadenectomy, so removal of all not draining, non-sentinel pelvic and periaortic lymph nodes in some cases. It's important to point out that while the majority of these patients had grade 1 or 2 histology, 30% had higher risk histology, which would include grade 3 endometrioid histology, serous, clear cell, or carcinosarcoma. This was a large study, which included nearly 350 patients who underwent sentinel lymph node mapping followed by complete lymphadenectomy. And this was performed across a large number, so 10 clinical centers by 18 different surgeons participated in the study across the United States. And this included both tertiary academic centers as well as community non-academic centers. So it was a wide range of clinical settings where this was performed. So again, the purpose of this study was to say, how accurate is sentinel lymph node mapping and removal for identifying sentinel lymph nodes, for identifying true spread of disease? When we talk about sensitivity and negative predictive value as a measure of success of this technique, what we're really identifying is the false negative rate, or what is the rate of us performing sentinel lymph node mapping and removal of nodes, a result being negative, but that negative result not being accurate. There being a false negative, meaning that we are missing spread of disease by doing this technique. So in this study, and to keep in mind this was done at a different time point, in modern times with increased use of this technique, our rates of sentinel lymph node mapping, both unilateral and bilateral, are far higher than what's described in this study. But within this study, this early sentinel study, 86% of patients had successful mapping, meaning those nodes were able to be identified by the dye. About half had nodes that were identified by the dye on both sides, so bilaterally within the pelvis. Nearly 60% of patients underwent a periaortic lymphadenectomy as part of their completion lymphadenectomy, meaning they had their higher lymph nodes that were assessed at the time of the surgery. And of those patients who had positive nodes, they identified about 12% of patients total with a very low risk of isolated periaortic nodes, very low risk of that being spread further away. But it's important to point out that 12% risk of nodal positivity is very similar to what was seen in GOG 33, that early study looking at lymph node spread in endometrial cancer. Of those patients who had mapped sentinel lymph nodes, 97%, or 35 out of 36, were detected with the sentinel lymph node mapping technique. You see here the main results of the study. The negative predictive value for this technique is very high, over 99%. and the false negative rate is very low, less than 3%. In this case, we would have high confidence that the sentinel lymph node technique is highly accurate and equivalent to lymphadenectomy and endometrial cancer. And we should be reassured that using this technique, we would have a very low chance of missing lymph node metastasis in this disease. Other interesting things about this study are that there's nearly 20% of those sentinel lymph nodes that were identified and were the only lymph nodes positive were found outside of what is otherwise thought of as the traditional lymph node sites of metastasis. So nearly 20% of those isolated positive sentinel lymph nodes were found outside of where we would traditionally look for lymph node metastasis in endometrial cancer, such as the presacral region or directly to the periaortic lymph nodes. 60% of patients who had nodal metastasis had disease that was isolated to the sentinel lymph nodes only. Again, within this study, patients underwent sentinel lymph node mapping and biopsies, followed by a complete lymphadenectomy. And so this study was able to describe those patients who had sentinel lymph nodes as being positive, and if there were any other nodes beyond the sentinel lymph nodes that were positive as well. And more than half of the patients had disease only in the sentinel lymph node that was removed. Now that's important to point out, not only because we do not think that there's a survival advantage to identifying more metastatic disease by removing those other lymph nodes, but also to point out that removal of those sentinel lymph nodes is a very high yield endeavor, meaning that if a complete lymphadenectomy were performed, and for whatever reason the sentinel lymph nodes were not removed as part of that dissection or missed, we would be missing what may be the only site of metastasis within the lymph node chain. Finally, nearly half of those patients who were identified as having positive sentinel lymph nodes, that nodal metastasis was only identified on ultrastaging, so that more intensive pathologic assessment that's performed on sentinel lymph nodes and not on complete lymph node resections specimens. And so, therefore, what this slide is really trying to describe is there are advantages for sentinel lymph node mapping and removal that go beyond a complete lymphadenectomy, meaning that we're removing higher yield lymph nodes. We are perhaps identifying disease that metastatic disease that may otherwise not be able to be identified by a complete lymphadenectomy, both through the use of ultrastaging, but also identifying lymph nodes that would fall outside of the traditional lymph node beds. For patients with endometrial cancer, sentinel lymph node mapping and biopsies accurately does predict the presence of sentinel lymph nodes with a very low false negative rate if there's adherence to our guideline endorsed algorithms, which would include assessment for metastatic disease, removal of any bulky or suspicious lymph nodes at the time of surgery, in the presence of failure of sentinel lymph nodes to identify lymph nodes, removal of all lymph nodes on that side of the pelvis, and the use of ultrastaging. Patients should still be counseled on the low risk of missed metastatic disease using sentinel lymph node mapping and biopsies, although we know from prospective studies, both from the FIRES trial as highlighted and others, that risk is very low. One other thing to point out is that not only in the FIRES trial, which included a significant number of high-risk histologies, other validation studies of sentinel lymph node mapping in endometrial cancer, which included even higher percentages of high-risk histologies, at similar rates of accuracy of sentinel lymph node mapping and removal. And therefore, this is a technique that is largely applied across all histologies in endometrial cancer. Sentinel lymph node mapping and biopsies increases the overall detection of metastasis through ultrastaging and through identifying of those nodes that would otherwise have not been identified as being removed with a full lymphadenectomy. And sentinel lymph node mapping really does minimize the morbidity that may be associated with a complete lymphadenectomy, both in terms of minimizing the duration of operating room time, but also the risk of lymphedema, which is increased with removal of more lymph nodes. And so by removing only 1 or 2 lymph nodes from either side, we really limit that risk related to lymphedema or swelling that is otherwise conferred through removing more lymph nodes with a complete lymphadenectomy. This is a short talk, so that is all I have for now for this talk. I do want to thank you for your attention, and I am happy if anybody is active on this webinar in the chat or in person. I'm happy to answer any questions right now if that's present. If not, again, I can always be reached through our hosts here after the talk for more specifics. But thank you again for your attention. And I apologize. Usually I try to include my cartoons in these talks for lack of a better venue, but I did not. So if you're interested in cartoons, you could also reach out to me too. I'm happy to share those offline as well. Thank you again for your attention.